Good morning, everyone, and welcome to another Thyroid by MDS webinar. We're bringing together leading experts to discuss advancements in thyroid cancer and thyroid disease research. My name is JP Rito, an endocrinologist at Mayo Clinic, and I will be your host today. Thank you for joining us. Today, we are privileged to have two distinguished guests. Dr. Linwah Yip will be the presenter of the article today. Do ultrasound patterns and clinical parameters inform the probability of thyroid cancer predicted by molecular testing in nodules with indeterminate cytology? And Dr. Erik Alexander will serve as our expert discussant. Let me tell you a bit about our speakers. Dr. Linwah Yip is an associate professor of surgery at the University of Pittsburgh. She is the chief of the Division of Breast and Endocrine Surgery and program director of the Complex General Surgical Oncology Fellowship. Her research focusing on molecular markers to guide the management of indeterminate thyroid nodules and optimize surgical decisions for patients with thyroid cancer. Dr. Erik Alexander is chief of the thyroid section at Brigham Women's Hospital and a professor of medicine at Harvard Medical School. With over 250 publications, he has contributed extensively to understanding thyroid nodules cancer as well as thyroid illness during pregnancy. He's a member of the American Thyroid Association most recent guidelines on the management of patients with thyroid nodular disease, cancer, and served as guideline co-chairman of the ATA's most recent clinical guidelines on the detection and treatment of thyroid illness during pregnancy and postpartum. But before we dive in, I would like to remind everyone about the podcast. Voices are podcast, Voices of Wisdom. Each month, we explored groundbreaking research and expert insights in thyroidology. It is available in Apple Podcasts, Spotify, or your favorite podcast app. And be sure to follow us. And now, Dr. Yip, the stage is all yours.
Okay, thank you so much. That was a very kind introduction. So I'm going to talk about this article today. I do have a number of disclosures. So first of all, I am not the first or the senior author of this paper. I was a multi-institutional participant, and also I'm not a statistician. And so there are a lot of complicated modeling that were part of this study. And so if you have some specific questions about how those models were derived, I can certainly find you the answer, but I cannot answer them today. And I usually, for most of what I talk about with ThyroSeq, I do put this disclosure in. I am an employee of the University of Pittsburgh Physician Group. We are an affiliate of UPMC. UPMC has licensed CBL Path for ThyroSeq, but I personally do not receive any direct or indirect compensation for ThyroSeq. So just a quick few slides about background. Again, these are things that you all know very well. So obviously, cytologically indeterminate B3 and B4 nodules are very common. And I think that this is going to be more likely and more common as we get better preoperative ultrasound risk stratification. So we looked at this study we looked at this in 2022. This is Kim Ramanel. She's one of my junior partners. We looked at 7,413 FNA biopsy results over a 7-year period to see how the distribution of the Bethesda criteria occurred over time. We did see a general decline in FNA biopsies per year. And implementation of TI-RADS here at our institution was in approximately 2018. And you can see here, so this is B1, B2, B3, B4, B5, B6, that in general, the likelihood of getting a B1, B4, B5, B6 biopsy was pretty much equivalent over the course of the 7 years. But as we are better, I think, at deciding which nodules really need to be biopsied, we're seeing a fewer proportion of benign biopsies and a higher proportion of AUS or FLUS biopsies. This is the same data in a different form. Again, it seems like in about 2018, now we had a lot going on during this time. I don't know that we can say that this is due to TI-RADS. Obviously, there are differences in Bethesda. We have molecular testing, lots of different reasons why we may have differences in cytology categories. But I think the take-home point of the study is that really we're seeing a lot of AUS biopsies currently in FN biopsies now than we were in the past. When we presented this paper at the AAS meeting back in 2021, multiple surgeons, I'm sure everyone here also has a similar kind of experience, also said the same thing. Gosh, every biopsy we have is AUS, what's going on? And so I think it really comes down to probably better preoperative ultrasound risk stratification. And so in general, the risk of malignancy within the cytologically indeterminate categories, as we know, varies anywhere from 5 to 75%. Molecular testing can be used as a diagnostic adjunct. This is in both the earlier ATA 2015 guidelines and also in the AAES thyroidectomy guidelines. And there are 3 primary commercially available tests. I'm really going to talk mostly about these tests today. There are many other tests that are available that individual institutions have developed, which also are wonderful. But we're really going to focus on these. And this is just a quick summary. There are 3 different kinds of tests: ThyGenX, Thyromere, gene sequencing classifier by Afirma, and then ThyroSeq version 3. This is a very busy slide. I have 3 basic take-home points about this slide. So number 1, all 3 of these studies were clinical validation studies. So all of these nodules did have histologic correlation. And so that's an unusual situation now. A lot of the studies that are currently available for molecular testing, usually benign molecular tests, don't go for surgery. And so this is one of the sort of definitions of clinical validation, is that the management of these nodules sort of occurred outside of the molecular test itself. Number 2, things like sensitivity and specificity are more related to the test itself. And you can see here in this slide that the sensitivities of all 3 of these tests are fairly similar, which is nice. And then the third take-home point is that how we use these tests really come down to things like negative predictive value, positive predictive value, and benign call rate. And so these are really reliant also on pre-test probability, or the probability of malignancy, incidence of malignancy, prevalence of malignancy, in these series. And this actually comes back, we'll be going through this sort of theme down the road. And so when you have a negative test, which is really the strength of these tests, we can say that the likelihood of this being a benign nodule is high, which is why this benign call rate is helpful, because if we have a test where only 10% are called benign, then it's really not a very helpful test. But you can see that all 3 of these tests have a fairly robust benign call rate. This benign call rate is, again, also related to the prevalence of disease, or the pretest probability, so that is very important to take into account. Now, the reason why I also show this is it kind of leads into the reason why we did the study that we're going to talk about in a little bit, is sort of this positive predictive value. And so the likelihood of a positive test being cancer really varies from 47 to 74%. Again, this varies by prevalence of cancer. But the question was, is there any way that we can better sort out which nodules with a positive test really are going to be cancer? And the data set that we used was from that last column, the clinical validation study for ThyroSeq. And this is the initial citation. It was a study published in 2019. In this study, the cytologists and pathologists were all blinded to the molecular testing results. Clinical management, as I mentioned before, was not guided by the actual molecular testing, and everybody had histology. This is the breakdown on your right of the study cohort. And really, most of the biopsies, of course, are benign. And so most of the primary study cohort ended up being this 232 patients, 257 samples, which we looked at, and the clinical validation was shown previously. And so we took this exact same study cohort for this study, which is the topic of our journal club today. And so the study aim was to examine if there were any clinical, cytologic, radiologic parameters that could potentially be associated with a probability of histologic cancer or NIPT, and to also assess the relative contributions of those covariables in different clinical models. And so this was a post hoc analysis. It included 10 study centers. You can see those centers here. The ultrasound features were assessed by a hodgepodge of people, admittedly. So 1 to 2 endocrinologists, surgeons, radiologists. It depended on the site in terms of who eventually came up with those imaging categories. We looked at both ATA risk stratification as well as TIRES, and we used the TIRES calculator. So again, thinking about the timing of this study, this was published in 2021. We were gathering data in 2019, 2020, and all these nodules were, assessed prior to, implementation of TIRAS. And so this was all retrospective evaluation. NIPT was considered the same category as malignancy, and then we coded molecular as positive or negative. Anything that was considered currently negative was also coded as a negative molecular test result. So these are the cohort characteristics. I think the main take-home point is that the cancer risk, NIPT risk is about 29% seen here. About half had positive, 40% had positive ThyroSeq results, 60% were negative. And then here are the ultrasound patterns down here. Fewer than 10% had either high suspicion ATA ultrasound or ATA, TIRADS 5 highly suspicious scores. So the majority of these were really fell into those intermediate categories. This is the univariate data. These red dots are the ones that were significant on univariate analysis. And I think, again, immediately the ultrasound features kind of fell out of that univariate analysis. And to sort of drill down a little bit more into what those ultrasound categories look like, you can see on the y-axis, this is the proportion that were cancer. The x-axis is the specific ultrasound pattern. At least with the ATA ultrasound risk, there seemed to be a slight slope in terms of increased malignancy risk with increased category, whereas in the TIRADS down here, it really didn't seem like it correlated a whole lot at all. And obviously these p-values are not significant. But because we were interested in ultrasound features and we wanted to include this as an important part of the assessment, we did use the ATA ultrasound risk categories because it did seem like there was some correlation, even though this p-value was not significant. And so that first multivariable model included only clinical variables. We thought it was important to really just look at how predictive purely clinical variables were in the absence of molecular testing. We initially did assess radiation exposure, but this data was incomplete in the database, and we also didn't have any idea of the latency time between exposure and development of cancer. So we basically ended up excluding that variable. But you can see in this multivariable analysis that ultrasound features were again not necessarily significant, but these other three variables were. This is the nomogram that was developed. The C index was not very great. So C index, just to remind everybody, 0.5 is no better than the flip of a coin. C index of 1 means that it's perfect. So 0.65 is actually not that helpful. We think that at least 0.7, 0.8 would be actually necessary to make any sort of meaningful clinical decision. So this is not great. The second multivariable model included that first one in addition to molecular testing. And so you can see that many of these clinical variables ended up falling out in terms of significance. And what's interesting is that if you look at this nomogram, you can really see that all these clinical variables over here, really the impact of these got significantly smaller. So they kind of got squished off to the left there. But really ThyroSeq molecular testing turned out to be very significant. Now this increased the C index from 0.65 to 0.89, which is much better, and a better R-squared as well. And then the last multivariable model was to really try to simplify that model and to really come up with the variables that were the most helpful in terms of, or to optimize that C index as much as possible. And so this is the one that we came up with using gender and molecular testing. And you can see maybe a marginal, really not that, that different, marginal improvement, 0.89, pretty much the same R-squared. And you can see that being a man increased your risk of cancer when you had a positive molecular test by about 2-fold. And so sort of thinking about, ultrasound features and that benign call rate, this is a figure just to help put this into context into some other of the papers that I'm going to just really briefly discuss at the end. We also looked at to see whether or not the ultrasound pattern correlated to the likelihood of having a positive ThyroSeq result. And again, neither one of the ultrasound features seem to be associated with positivity of molecular testing. So why is this? So why was there no association? Well, I think, the type of nodule that we see, so this is a very classic sort of TR5 or ATA highly suspicious. It's lobulated, it's hypoechoic. In some of the other cuts, there are some microcalcifications, maybe some extrathyroidal extension here, though it's a little bit hard to tell. And so this would probably be what we would think would be a TR5 or high suspicious. And we know we've done studies on this before. Many people have reported it in the meantime, that these are almost always, papillary cancers or classic papillary cancers. These type of features do correlate with BRAF-like tumors. And so if you go back to that initial study where we did the clinical validation, most of the tumors that we saw within the data set were actually not BRAF tumors. This only incorporated about 12% of the positive molecular tests, but really most of them were RAS-like or copy number alterations, and these tended to be follicular variant cancers, follicular carcinomas, oncocytic carcinomas, and these are a little bit more difficult to tell on ultrasound, based on ultrasound features. So I think that's where the issue is. So obviously there are a lot of limitations. There's no central review of images. And so I think certainly, it was 10 different sites, different people reading different kinds of images. So who knows what that inter-observer variability was. We had a very small cohort, less than 10% of the cohort were ATA high ultrasound features or TIRADS 5 nodules. And so certainly subject to some, bias from that standpoint. This is a post hoc analysis, and it's certainly not powered for some other potentially helpful variables like age, ultrasound features, or even Bethesda criteria. And of course, there's no validation of those nomograms. It was just a single data set validation. We were able to conclude that molecular testing seemed to provide the highest association with histologic malignancy or NIPS-P. Male sex also seemed to be associated with an increased risk, about twofold increased risk of cancer, and ultrasound features, at least for what we could see, were not particularly informative. Now, since then, there have been two different studies. This is Azarian et al. This is the group out at Ohio State with Jens Sipos. This looked at ultrasound features in the FIRMA in cytologically indeterminate thyroid nodules. And then the second study by Michael Ye and Masha Livitz out at UCLA, they also looked at whether or not ultrasound risk classification could help better risk modulate, what we're seeing with molecular testing. So this is just sort of a brief overview of both of those studies. You can see the number of nodules. Now, again, our study included 10 nodules with suspicious FNA. These studies were really just limited to B3 and B4. This initial study was just GSC. This one included both GSC and TSB3. Ultrasound classification in the Ohio State was 2 endos, 2 concordants. And so I think that whole idea of inter-observer variability kind of goes out the window in this situation. A little bit more variability in the second study. I think they described 10 to 12 different radiologists and endocrinologists who helped sort of come up with a classification. Again, similar, NIPT was considered malignant in both of these studies. The management of the nodules of GSC was suspicious. These nodules went to surgery. Benign nodules went to benign, were considered benign, and went for surveillance. A similar thing in the WHO UCLA study. If it was MT positive, those nodules had surgery. Not everybody had surgery. It was 82%, and some of these actually did go to surveillance. And then of the MT negative, again, some of them went to surgery, but mostly went for surveillance. So some heterogeneity in sort of the back end of the management. In the Ohio State study, you can see the numbers here. They had a 82% benign call rate overall for the entire study, 48% malignancy among those that were suspicious. And you can see right away, so they're looking at the benign call rate, remember? So that's that proportion or likelihood that you're going to get a benign molecular test. Again, driven a little bit by the prevalence of pretest probability. And so overall, it was 82%, and they already right away saw differences in whether or not they were seeing Bethesda 3 nodules versus Bethesda 4 nodules, which kind of makes sense, right? So Bethesda 3 nodules have a lower rate of cancer, so of course, you're going to have a more likely chance of getting a benign result. But all of the data also subsequently was stratified by Bethesda category in addition to imaging. So here in both of these graphs down here, the dark bar is the higher risk ultrasound features. This is ATA on the left side and then TIRADS on your right side. And so you can see, at least from the ATA high risk, unlike ours, they really didn't see a whole lot of difference between the high risk ultrasound features versus the low risk features. The benign call rate was essentially the same, although there certainly trended in some of these situations towards being a little bit more, again, similar thing, where if you had a higher risk of cancer, you had a lower likelihood of having a benign result. In their TIRADS, they actually did see a p-value in the Bethesda 3, and so their conclusion was that ultrasound is very helpful in terms of stratifying whether or not you need molecular testing, and also it can be helpful to help you decide how to manage those nodules that are benign or suspicious on GSC testing. This is the UCLA study. Again, they had both studies, tests, so GSC as well as ThyroSeq. And this is their GSC data. And so their benign call rate was 65%. And you can see here, this left hand are the low intermediate suspicion nodules, and this is their high suspicion nodules. Again, they saw a very low proportion. So only 9 of these nodules were considered a high suspicion. But again, the benign call rates differ significantly. When you have a higher risk of cancer, the likelihood of having a benign molecular test is much lower. This is their TSV data, same exact thing. They had 10 nodules that were considered suspicious in their cohort. And again, none of these nodules were TSV3 benign. And so certainly very interesting data from their standpoint. And so I think this is really the key, that in this data set, if you just have a sonographically suspicious nodule just off the bat, it's an 80% risk of cancer. And so I would argue that with an 80% risk of cancer based on imaging features alone, I don't think you really need any more testing, right? So you don't really need to spend the healthcare dollar to use molecular testing. Certainly a biopsy would be helpful just to make sure, but certainly I don't think anything additional is really necessary. And then this is their multivariable analysis. And again, they had similar variables: age, sex, nodule size, Bethesda category, ATA risk stratification. And you can see that they actually did see some p-value with ultrasound features, and also they saw a very strong predictive ability of molecular testing with cancer. So I think overall, in summary, institutional pretest probabilities of ultrasound categorization, including ATA risk or a TIRADS, whatever you choose to use, and Bethesda classification are really important to know. So how you interpret these molecular tests, I think really depends on what your pretest probabilities are. So if you have that 80% risk of cancer based on ultrasound alone, like they do at UCLA, then that's great. I don't think you really need to do any additional testing. And it's highly unlikely that you're going to add any diagnostic utility with molecular if your pretest probability is really high or really low. And of course, if you're already considering surgery for other clinical reasons, then really probably adding things like molecular testing is not super helpful. I do think, and this is a completely different topic, but molecular testing results can provide some prognostication that can certainly help inform extent of surgery and our appropriate list of surveillance, especially if you have somebody who you're thinking about, even if it's molecular testing positive, you may, if it's an 80-year-old with a bad heart, you may not necessarily be aggressive with resecting a NRAS positive nodule if they don't necessarily need it. But if you see something that's high risk, then certainly that may be more compelling. And so I am going to end there and let Dr. Alexander take over.
Thank you, Dr. Yip. That was wonderful. Dr. Alexander, the stage is yours.
Thank you. It's a great presentation and great data. Thank you, Lynn, and an honor to be able to discuss and really just put this in perspective. And of course, it's one person's perspective. So always the key is there's a lot of great experts there and many great experts on that paper. But just 10 or 15 minutes kind of on the space and broadly to give context to what Dr. Yip just went through. And my disclosures, I've been involved in this space for decades. But the starting point for me and to share perspective broadly with the audience is this. And just to repeat what I think Dr. Yip went through, which is all of us clinically have known for a while that there are many different risk factors that can help us individualize care as it relates to thyroid nodule evaluation, really for the purpose of defining and detecting thyroid cancer, because the assumption is that treatment of that thyroid cancer will improve some endpoint, likely survival or morbidity. And the slide here really just points out that we've long known now increasingly there are 4 big buckets, if you will. There are demographic risk factors, whether that be sex or age or whatnot. There certainly is radiographic risk, the most common of which, as mentioned, is ultrasound, but there are others like PET scanning and whatnot. Cytology, of course, a major risk factor assessment, and the institution of the Bethesda system, really important. And then increasingly in the last decade has certainly been molecular assessment, in particular for diagnostic use. And the goal is to bring these together because we want to initially risk assess, and we often risk refine, and we want to have an optimal treatment strategy. But the real point of this study and many others is that, while it's easy to kind of talk about this at 36,000 feet, how we integrate them together is more difficult. And that's where this study really adds great value, is it's starting to dig into the weeds and really help us understand the multivariate assessment that we're trying to apply in the clinical domain. And so with congratulations to Lynn and the whole team, and to really make note that this is a huge team of experts who've been involved in the space for a long time. My kind of top level initial starting point as I think about the article, there's always positives, there's always constructive pieces to every article out there, but I'll start with the positives, which is that, of course, this is a large multi-center trial, and those are hard to pull off. And then the second thing I often look at is there kind of a standard that kind of fits with what I see in the clinic, with what we all see in the clinic, and there absolutely is. This is a very typical cohort. You can look at the average age of patients here evaluated. You can look at the average size of their nodule at 2 centimeters. The distribution you would expect of patients coming in for evaluation, whether it's male or female, predominantly, of course, female in this business, and everything fits. So there's kind of that just general awareness that this is a cohort we would all see, and it gives a lot of, I think, extra validity to the study itself. And along those lines, as we will talk about here more, the univariate risk factors do align with also our expectations and other data that are out there. We've long known that males have a higher risk of a nodule proving cancerous than females. We also know that younger age, almost as a linear function, is similar, that those who present with a nodule in their 20s clearly have a higher risk that nodule will be cancerous than those presenting in their 60s, and the same with Bethesda scoring. So to me, these are all very important validations that fit with the broader data. And then it makes me want to kind of look at then the multivariate analysis, because I trust the data set that's being analyzed. And in fact, this is one of the few quantitative multivariate assessments. So it is trying to bring down that question of how do you pull all the variables together. Now, as Dr. Yip had mentioned, I guess if we look at the cautionary pieces to any article, we are always looking to hope to find a primary evaluation of a prospective blinded trial. Not everyone can do that, nor is there funding and availability. In theory, this is a post hoc analysis, but at the same time, this study, I think, so multi-center, prospective, and well done, and the initial article, of course, so well respected that I have no real concerns with a post hoc analysis here. I think the data are equally as valuable. So that one actually really not too high on my radar screen. What's notable, of course, is that as those of us who kind of are in the molecular space know, there's a lot more data that you can gain from the ThyroSeq version 3 results. And one thing I would just say is here in this study, it's listed as positive or negative. But of course, when we use it clinically, you get back specific data on specific mutations, and there's probably something there that could be explored as well a little bit more. I do think probably the biggest cautionary tale, as Dr. Yip mentioned herself, is the lack of a centralized ultrasound review. And I'll show you some data that speaks to kind of that issue, not unique only to ultrasound, but there is kind of an inter-rater reliability concern that we always want to keep in front of us, that these single variables don't always reproduce themselves when they're looked at again in a blinded fashion. And I think what I'll then comment on at the end is just to make sure that we as a community always understand the broader aspect of how we think about nodule evaluation. And while this is kind of a snapshot within that broad continuum, we don't want to lose sight that at times ultrasound can be useful somewhere else in that continuum. So a few slides on that ahead. And this is, I took this from a publication we put forth back in 2008. This was in JCE&M. Just to kind of comment that our understanding of the univariate risk factors has been out there for a while, whether, again, it's clinical, radiologic, and more recently we've updated that and published in Lancet Diabetes and Endocrinology. So we're getting our handle around it and getting better at it. But what's so notable is in each of those publications, of course, we can list out 20, 25 different variables that we're coming to understand. But in this situation, as it relates to this question at this point in the continuum of care, it was very just interesting that you pull the multivariate analysis together And there's really two variables, as was noted. So I think that's so helpful to really help us understand, to simplify almost what we do in the clinical domain. As to what I mentioned earlier, which is just be a little cautious to not overinterpret, I wanted to share that concept that we have to understand while we're gaining value in understanding how a variable predicts cancer risk in a nodule, we also have gained great value in understanding the limitations of each single variable, meaning the reproducibility and predictive value of those variables. And I'll just show you the two here that are really front and center. One is going to be how we think about the reproducibility of an ultrasound finding in a nodule. That's going to be on the left. And then the reproducibility of a cytologic diagnosis on the right. So take on the left the data by Perschietti in 2020. This was a prospective blinded interpretation. They simply had 100 consecutive nodules. And they really just said, if I took the same image and gave it to two expert radiologists, how often would they agree to predict those sonographic findings on the same image? And the answer is not all the time, right? We look at so-called kappa values. You want that to be as high as it can be. And generally, for most findings, sonographic criteria, you find that the kappa value is roughly 0.4 to 0.6. There's kind of moderate agreement. And we all see this in clinic, right? What somebody calls microcalcifications. The next radiologist looks at the same images and says, geez, I really think those are colloid, crystals, and that's certainly a low risk scenario. There's nothing wrong with that. That's just a limitation that we all have in our domain. It's just an impossibility to be perfectly predictive at times. And we see the same on the right as it relates to FNA cytology. At CBIS Suber ourselves, we published this now a decade ago. This came out of this concept that we were collecting a lot of cytology on a multi-centered study. And we asked the question, if we took the Bethesda category first called out by the local cytologic expert, and in particular focused on Bethesda 3, 4, and 5, if we sent the exact same slide to a second cytologic expert and said, please read it, how often would they agree? And the limitation, of course, is in Bethesda 3 and 5 in particular, it's striking that you probably have a 1 in 3 chance that the exact same slide is read the exact same way by another expert. That means there's a 2 out of 3 chance that they would call that Bethesda 3, a Bethesda 2, or a Bethesda 5, or whatever it might be. That, again, just the limitation, the difficulties in terms of assessing what are hundreds of cells underneath the microscope. And the second or third piece that I'll mention here in terms of the study is just putting it into the broader perspective as well, where I think Dr. Yip showed very well how, as we talk about along the continuum, if you have a cytologically indeterminate nodule, what do we use for other variables and how do we think about molecular testing in conjunction with things like ultrasound? Very important. But there's other utilities for ultrasound as well, earlier perhaps in the continuum of care, and I'll just show you these data. Of course, we assess and detect nodules with ultrasound. We know that palpation is simply not as good. But I've always been struck by these data by Horvath. So this was a prospective validation of TIRADS, looked at about 500 consecutive nodules. But what was very unique here is they not only captured the ultrasound, the sonographic findings, but then everyone went to surgery. So we had final kind of gold standard histopathology. And then they graded, of course, the images using the TIRAD scoring system. And what's notable is when they looked then for the presence of cancer, they essentially found no cancer in TIRADS 2 and TIRADS class 3 nodules. All the cancer really lied in the higher risk TIRADS 4 and 5. But that represented 34%, almost 1 in 3 of all the nodules. And so there still is, of course, utility then for ultrasound in that perspective, because you could make a strong argument that you see these low-risk nodules that they don't even need to be aspirated. You won't even find yourself in this question of indeterminate cytology, the need to use molecular testing, because you can kind of stop the train early on. So always broadly thinking about how data fits within a broad continuum, I think is of great value. I'll just mention too, just where we're at with molecular utility and use of molecular data, because it's evolving so fast. I'm going to move just a little bit on this slide from what we're talking about here, which is the use of molecular diagnostic tests. That's the Afirma, the ThyroSeq, just to kind of also have a little bit of retrospective review on molecular prognostics, right? How does it kind of help us individualize care decisions or next steps in care? And when we were talking about this now a decade ago on the still currently active ATA guidelines on thyroid cancer, we actually shied away from saying that we should be using molecular testing in that prognostic sphere. And it's kind of this univariate, multivariate kind of thing that we were seeing because somewhat concurrent to that, Ming Zhao had also shown us in some publications that BRAF V600E positivity was associated with a survival detriment when it was looked at in a univariate analysis. If you read Susan Mandel's editorial to that article, it was notable, though, that in the multivariate analysis, the p-value didn't hold. You already knew that risk was high because the histology showed aggressive features, or the extent of lymphadenopathy was already there. So again, at times, one variable is very much predictive of other variables that we see. But boy, that's changed, right? We are continuing to see over and again that you can find in unique subsets how molecular data is beginning to help us independently prognosticate. I'm not going to go through all those newer studies, but a decade of time is a lifetime in this business, it seems, because things are moving. So I want to congratulate Lynn, and I want to congratulate the whole team, many of whom are all my colleagues. I think the article is great, and I think putting it in perspective with the other two articles that Lynn mentioned also of great value. My take-home points is that I think molecular testing does have value, especially though in the right patients arrive to the right nodules at the right point in care. And that's the key, right? Is that kind of this standard blanket approach to say molecular testing belongs here for everyone probably doesn't work. We really do need to be thoughtful about where we put it. And we're starting to figure that out, which is where, how much, and to what degree each variable contributes to the individual understanding. And it's, of course, always the multivariate analysis that's critical. You can still use those single variables in other points of care, and we shouldn't lose sight of that. And there also, I just want to call out, there can be great value in secondary analyses of these large trials. So much effort and money is put in at times to these multi-center studies that I'm really happy to see people going back and also trying to use the extensive data available to answer yet another question. So congratulate the whole team on that. When I walked into the business as a young, now junior attending in 1997, the world was very simple. I was told just to biopsy any nodule that was over a centimeter, and ultrasound had come online, and use that because it's helpful. But it's a very different world in 2024, just 25, 30 years later. We have a lot of understanding of better diagnostic tools, diagnostic steps where we can at times actually slow things down, and the important considerations. And I'm fond of saying in the current era, we're not guided only now by what we can do, but a lot more about really thinking about what we should do. So with that, I'm going to stop sharing, and I want to just thank the whole team for giving me the chance to give perspective to it. And together with Lynn, welcome to take any questions.
Erik, and that was wonderful. And again, I appreciate both of you. And I think it's wonderful presentations and very well balanced presentations, I will say. I particularly appreciate the nuance of putting these results in the whole context of care. I do think that this is a gap that is not always discussed, meaning we fraction these patients as ultrasound alone, biopsy alone, molecular test alone, when in reality it's a continuing assessment of risk. So I really appreciate that. This is wonderful to see both of you talking about this topic. And we already have a comment from the audience, and I will encourage the audience to post questions in the question and answer chat bot. And Dr. Fries is asking, what about the use of molecular tests for diagnostic determination of radioactive iodine avidity, as well as potential directed medical therapy? I think, Erik, you mentioned this briefly, but if you want to expand here, mostly about but really patients that can be better candidates for radioactive iodine.
Yeah, it's a great question. I mean, the broad starting point to that, in my opinion, is that when you think about, in this case, molecular understanding of disease, I think about it in three big buckets for how those data can be used. And we've talked a lot about molecular diagnostics. That's the Afirma, the ThyroSeq, the Interpace product, et cetera, and really applied there to cytologically indeterminate nodules. I'm on the other end of the spectrum. I think you can use molecular data. In very advanced disease, we see routinely poorly differentiated anaplastic disease. We see genomic understanding of what's going on in that individual cancer to drive hopefully a matching targeted TKI or understanding of what would benefit the patient most. Those are two different uses. There's a third bucket, which is molecular prognostics, and I think that's where this question is kind of getting at, which is, well, can we understand better then how to apply the next point in care? In this case, the question radioactive iodine. Is there a marker prognostically predicting iodine avidity or MEK inhibition or whatever it might be? And I think the answer is, well, not quite, but a lot of us are all thinking about this and looking at it. So I don't think we quite yet have exact determination as to iodine avidity. There's a lot out there that would suggest BRAF positivity is not as iodine avid, Hürthle cell carcinoma is not as iodine avid. In my mind, does that mean you should never give radioiodine to those cases? I don't think we're quite there yet because we really don't have the prospective kind of randomized data on that. And sometimes there can still be a small signal of benefit, even if we think that the basic cellular mechanism, might speak against it a little bit.
Yeah, wonderful. One thing that bringing to the practice, I don't see this coming along in the talks, is that the issue of reproducibility is actually an interesting thing that we can use in our practice. So you mentioned, Erik, that just asking a second, sometimes expert cytopathologist might change the diagnosis of Bethesda. Similarly, just repeating the biopsy, not just the second opinion, but just repeating the biopsy does have different deterministic pathways. So there are a couple of things that we still use in practice that I'm starting to hear less and less, which is, for instance, for Bethesda 3, instead of moving forward quickly with molecular tests, one can actually rebiopsy those ones or do a second opinion kind of process. And by doing so, many of those patients will avoid subsequent utilization pathways. Dr. Yip, do you want to comment on that, perhaps reflecting on those practical things that we can do even before molecular test?
Yeah, no, I 100% agree. I mean, we do that. I'm sure everyone does that from day to day. You look at something on the ultrasound and someone calls it a TIRADS 5 in particular. That TIRADS 5 is always that problematic category. And just as Dr. Alexander mentioned, you look at it and you think it's colloid. And so it's certainly easy to, get another opinion, have somebody else take a look at it and just see what they think. But I think I agree. I think having another opinion of getting a second ultrasound, maybe by somebody, a more experienced ultrasonographer or doing it yourself in the office, I think is a very valuable thing to do in the clinic, especially if you see some discordance between what you're thinking with the clinical features and sometimes even the biopsy when it's already been done. I think the second cytology read is also very, very important and helpful. I think there's certainly some issues with fixation and preparation of the slides that can sometimes make that second read a little bit more challenging from institution to institution. But certainly, if we are concerned that we don't think that it's been sampled, or maybe it was something that was done under ultrasound guidance, I think it's certainly very reasonable to repeat that biopsy. I don't have the data in terms of whether or not that helps, but studies have been done that we know that AUS, a second biopsy, leads to a benign biopsy about 50% of the time. So I think it is very helpful to keep that in mind.
Absolutely. Erik, do you use any of those tools in practice?
The tools of repeating or reanalyzing,
Yes.
I agree with Lynn. I think there's a complexity to that, is what I'll say. I think the reason that we can do that in our field is that we're dealing with generally a low-risk entity. We're dealing with most of the time nodules proving benign. If you just play out the sheer odds, right? 90% will prove benign of any given cohort. And even when you're dealing with thyroid cancer, you're usually dealing with a low-risk disease, right? Whereas if you miss something, there really is good data that so-called rescue surgery down the road seems equally effective 6, 12 months, 18 months down the road for most of the scenarios. And I bring that up because you kind of have two sides to this equation. As Lynn mentioned, absolutely, if you had kind of there is a component of Bethesda 3 in particular that is a limited sample, and it really is if they had more data, more cellularity, they'd probably, all the pathologists will say, I could make a better judgment call of that. That seems very logical then to try and get another sample, or whatnot. Having said that, if you do have a good sample, the argument that you simply send it to another set of eyes and you get another reading and somehow it's accurate on the second one, I don't know. I think you could send it to a third person and flip back again. The other side of the equation is people would say, well, look, if you have some inherent uncertainty in any given variable, like ultrasound interpretation, like cytologic interpretation, that really speaks then to the power of the multivariate analysis or the multivariable use. So that's where you would say, look, if there is already some error in cytology, that's when I want molecular testing because it's independently going to be additive in a different way to that risk assessment. Now, there's a lot there because there's cost and there's other utility and et cetera, et cetera. So I don't want to claim that's where we should be going, but I think that's how I think about it. We're lucky it's a low risk entity here because we can be a bit more conservative. We can take our times to have other people put eyes on the same slides or images because we generally don't put the patient at risk by doing so, even if we're wrong and it is a cancer, right? We have time. So that's the way I think about it.
Yeah, makes sense. So one of the things that you mentioned, Erik, which I think might be an interesting take-home point, is I do see molecular tests becoming a reflex test. I see the practice in which people order by cytology, and automatically, when it's Bethesda 3 and 4, it follows molecular test. I think both of you are mentioning be careful with that because you can reassess this by using ultrasound features, as Lynn said. Might be that the high risk features, the high risk nodules are already high risk, so it will not change much. The same with low risk. And so what is the take home point for those of the audience here that likely are in a practice that are using reflex molecular tests? Should they, be careful about this process? Because I do think that the field is changing towards that. Lynn, you want to start?
Yeah.
So I don't think it's necessary. I mean, I think in Bethesda, and I think you have to take the different Bethesda categories into consideration, right? So Bethesda 4, interpreted by a reliable cytopathologist, and everything seems concordant. The imaging looks like a Bethesda 4 nodule, the cytology is like that. I think that in that situation, in many cases, molecular testing is helpful. Now, if it's big, and it's growing or some other reason, or it's pet habit or something else that you're concerned about, I think it's not always additive in terms of how much utility there is with molecular testing. And so I think there's lots of situations that I can think of where you don't need the molecular testing. We are not reflexive here, but we are a little bit spoiled in that, biopsies at all of our different sites, we do save a specimen in a freezer in pathology for molecular testing, so we can easily run it if we need it. But that is a separate order, and we usually do it after we've assessed the patient. But I think in general, and from a cost and sort of a utility standpoint, I don't know that it makes sense to do it reflexively for everybody.
Appreciate it, Lynn. I will let Mark. Mark has a question.
Yeah, thank you both for your presentations. Truly, really educational. I want to step back just for a second and maybe bring this back to JP. Should we as clinicians be discouraged by these very unreassuring kappa values with respect to both ultrasound, cytology, even histology when it comes to tall cell variant or features? And maybe JP, you've done quite a bit of work in the space of AI and in medicine. Do we have hope that there will be a ground truth that will emerge in the future? Or are we destined to this level of uncertainty and inconsistency across folks who are interpreting?
No, that is a great question, and I will respond in two ways. One is that as a clinician, I welcome the uncertainty. I actually appreciate the uncertainty because otherwise I will not have a job. And that makes me actually, the conversations about uncertainty are the best conversations because otherwise it will be a standardized packet of everyone receiving biopsy or no biopsy, and that's it. So I really appreciate uncertainty. The best conversations are the conversations about uncertainty with my patients, how to proceed with a small nodule that looks suspicious, how to proceed with a Bethesda 3, a Bethesda 4. So really, those are the great conversations. Now, yes, you're right. So if you think about AI, um, AI sees the world in modalities. Modalities are the way that we perceive data, perceive things. In the way that we are working right now for molecular tests, we're working in kind of the data that we perceive as a human from images, from the cells, and from the genes. The, the AI will amplify that by expanding the use of these modalities. So right now, I think breast cancer, for instance, use all of these multimodalities to understand from cytology. They combine with histology, they combine with ultrasound, they combine with all the images that you can get, and constantly, and every time that they publish this, the performance is much better. So once the models are developed, I think the modality, the multimodality will be able to perform much better, but will never resolve issues of uncertainty. Because remember, the uncertainty is, one is the risk factor, but the other one is what it means for this factor for the patient. And that kind of uncertainty will never be resolved. So yes, AI will help quite a bit. Now, the big problem that we have with AI in this field is reproducibility. So how do you get the gold standard when two radiologists agree 15, 20% of the time? So going to the Erik's presentation about those papers, for instance, you can start seeing that the ground truth, the way to train these models is going to be challenging because then you have to come out with a better gold standard in which maybe two experts get consensus on what the truth is. So it requires a different kind of development of gold standard. And I would like just to mention that there are two more questions from the audience. I would like them to address. Dr. Shah is asking, well, says, thank you very much for the presentation. Was there any particular ultrasound feature associated with a statistical significance or positive molecular test? Lynn, I think you mentioned that I'm not sure it was, I don't think it was assessed, but can you expand on that?
Yeah, so in our paper, we didn't see any significance, but in both of the Ohio State papers and also the UCLA papers, they did see significance with the higher risk nodules. So the TR5 and the ATA high risk nodules, those were more likely to be associated with a positive molecular testing. And in Ohio State, especially if you had a Bethesda 3 biopsy. So.
But any features like the calcifications or hypoechogenicity or any of those?
Typically, no. I don't think
No.
any of the papers really drilled down that deeply into specific features.
Dr. Gonzalez, Camilo is asking, well, saying, congratulations on your work on a very interesting presentation. In the case of patients with a multinodular goiter who has an intermediate cytology biopsy of a prominent thyroid nodule, how does the presence of a potential multifocal disease affect practicality and decision threshold for using molecular diagnostic tests on this nodule? Erik, I think this is the question, putting everything together, and particularly with just few patients present with just one nodule in one lobe, that in practice we have patients that have multiple nodules.
Yeah.
How does it change management in those instances?
Yeah, I mean, I certainly in any given population that walks into any of our offices, I bet 50% will be a multinodular goiter, right? Two nodules over 1 centimeter as a general definition. And what we also know is that in a multinodular gland compared to a uninodular gland, the risk per patient of malignancy is about the same. So when you have more than one nodule, you have to hunt a little bit because they're not all assumed to be malignant, and one nodule could be cancerous, the other's benign. And that really has led us to use ultrasound primarily to guide which nodules to aspirate first. That's the best predictive, I think, variable we have, as opposed to size, for example, of a nodule. So I do think you want to use that as to kind of how you strategize. I think the other big picture piece to this, of course, is you still will use your own thought to understand malignant risk in each nodule, whether you need a molecular test or not. That's the decision we've just kind of walked ourselves through. I think the downstream piece to it all is, well, if you find malignancy, there's the complexity then to, do you want to remove it? Do you pursue a hemithyroidectomy in your total? Like, there's a whole discussion on that. And I do think you just want to be thoughtful about all of the nodules as you walk into that decision, because you can treat one nodule in a vacuum and find that 2 years later you're back chasing the other nodules you left behind because you didn't evaluate them. So
Mhm.
I think all of us just want to be and are holistic in terms of kind of that general thinking.
Perfect. Let me ask you something. Are we in the field and the way that we study, are we lumping the patients that they are not similar, particularly with Bethesda category? I'm always surprised that Bethesda 3 is actually 6, 7 categories within one. Bethesda 3 has different actually associated risk of malignancy if you have a Bethesda 3 read as a tibia, as a Bethesda 3 read as others, like what we used to call floss. But then we lump them together. But we know that the risk of a tibia is 50% and the risk of floss is maybe 10%. So should we continue to lump them together? And if so, what are the consequences of doing so? And Lindy, I know that I'm asking because you lump them together in the paper, but I know that others have done the same.
Yeah, I mean, right. We didn't drill down, but that is a very interesting question. I mean, if you look at features that potentially increase your pretest probability of cancer, then likely that's going to alter sort of that benign call rate or the positive predictive value of molecular testing. And so I think that is one of those important factors. We didn't look at it in this paper just because it would further reduce our numbers. But I think the current Bethesda does leave some headway for separating nuclear atypia or calling out nuclear atypia when you see it, right? But that's a great point.
And I will encourage everyone to talk to their pathologists and to discuss how confident they feel about reporting this, because I do think it adds quite a bit of value, and it's already there. The data exists. Erik, that you get reports with Bethesda 3 nuclear atypia versus others, or you get just Bethesda 3?
Right now, the top line reading still is a Bethesda classification, and there are often paragraphs and notes, and to give a little credit to our cytology team, there used to just be paragraphs of descriptions, and what Bethesda did is try and bucket a little bit more of a common language and common risk assessment. So I agree with where you're going, JP, which is Bethesda 3 by far is the broadest and most common of the indeterminate categories. So there is utility in thinking about the evolution of how that could be parsed out. Having said that, the creation of Bethesda 3, 4, and 5 as an entity was a positive move in our field, 15 years ago.
Absolutely. Now, Erik, let me ask you something. I've seen this trend of type of Bethesda over time, and Lynn, you presented this beautiful data. Are we seeing more Bethesda 3 because we're doing fewer biopsies? Are we better at choosing biopsies, or because we have molecular tests?
Yeah, probably both. I think as Lynn mentioned, the more you're able to screen and a little bit more risk assess before you move towards a biopsy, certainly as I showed the Horvath data, allows you maybe to stop the train before you even get to that point. And there probably is some piece to that we're being more selective about who we're biopsying and sending to surgery. And we have seen some data nationally, internationally, that so-called surgical yield is improving, right? That we're getting more cancer out of who we're choosing to operate on. That's what you would want. But I think you're absolutely right, JP. At times when there is uncertainty, and I'm not a cytologist, but if I were and I knew I had some help maybe in a molecular assessment, I might be more apt to maybe ask for that, which means I wouldn't be as strong as saying, but this is clearly benign or something. There's probably a little bit of that too.
So we actually looked at it in that paper because that was a question that we were we made that assumption that they were relying on molecular testing, but we actually did look at the positivity rates of molecular testing in a cohort before that sort of dip and after, and the positivity rates were the same. And our cytologists have actually been consistent, and so that was very reassuring for our cytopathologist who was sweating buckets up until then. But yeah, we wonder, but I think at least
Interesting.
in the small
Great.
data set, it seemed like it was not the case.
Well, this was wonderful, and we are up to the hour. And again, Lynn and Erik, really wonderful presentations, and I really appreciate you putting those results into the context, into practice. And this is a very practical and pragmatic kind of discussion. So I appreciate that. And again, thank you everyone for coming and attending. And please continue the interactions in our YouTube channel. And again, please join us to the other webinars that we have. The next week, we actually have 2 more board with Mike Tuttle. So it's always fun. Take care.
Great day.